We might get started. I'd like to introduce myself first. My name's Steve Young. I'm the trauma lead, current trauma lead for WRO, and I've been working hard with Mark Brennan and Eves Marks and Ian and the executive to bring a few changes to this year's WRC 23 at Lanzarote, and I hope you'll enjoy it. What I'd like first is there's 21 people here. I'd like a quick show of hands to see who's actually competing. If you are, if you could just raise your hand. One. This one, it's just at the top of the screen if anybody's struggling. We've got 3. Cool. 4, nice. Okay. Rightio. That's good to see. Okay, thank you, everyone. Yeah, I got involved with rescue challenges about 4 years ago and competed last year in Lanzarote. I've been a paramedic for 21 years and rescue officer, special operations officer for 10 of those. Also have spent 25 years as a reservist in Air Force. I've since retired from there. That's a little bit about me. Just into the team, as I said, we have a trauma team working group, and we have there's been a few changes that have been requested and some that have just needed to catch up with what's happening. So what we're going to do, and this presentation will be most beneficial for those who are competing and those involved with the teams. And anyone who's interested in rescue challenges. So and this is a bit more of a trauma focus as well. So I'm going to go and try to share my screen. Will be that one. Okay. Let's have a look. And this one for me. Okay. Cool. Everyone should be able to see, hopefully, the PowerPoint. If I can get just somebody to let me know that that's what they can see. It should be scoring guidelines and the white screen, not the black screen. Yep, thanks, Cameron. That's great. So it'd be a miss of me not to mention the previous 4 webinars who have provided the guiding information for a lot of the changes this year. So if you haven't seen them, you have the first webinar was Tim Nutbeam and spinal injuries following an RTC. We then had James Kumar with vehicle relocation, Johans, Evan and Brad with their trauma injuries and immediate treatments, and Mike with his record on primary and secondary survey. As I mentioned previously, There was a desire for change this year post the survey from last year's WRC. And there was some new research, and it just wasn't being reflected in the scoring or in the challenges. So this presentation is about how we have incorporated these changes into WRC. Trauma, specifically this one, though, will allude to the extrication challenge as well. Things that we will discuss will be the spinal management and how we incorporate the exit project into our spinal management. A patient-centered approach, which is a huge change, not in the way we practice, of course, but in scoring in the challenges this year. One of the other key changes is that we have moved to a CA model, or managing our catastrophic hemorrhage first. And the slides will show that further. I'm excited to talk about the introduction of advanced procedures as a voluntary option this year for our trauma teams, and where we will be moving forward in the future. And then, of course, answers, and I'm sure there will be plenty of questions, and I hope I have all the answers. That we do have Ian and Mark here as well, so we should be good. Okay, moving to the next slide. Just on our spinal care guidelines and expectations. So this is about incorporating research and what we've learned. So none of this should be new to anybody. Our high-risk mechanisms of injury are there. Our actual code: hyperextension, flexion, our lateral flexion and hyperrotation, and our elderly or patients with diseased vertebrae. So and there's a reason why I've gone straight here and not introduced a whole number of scenarios that would indicate that there's been any of these mechanisms, and that's because you can't list them all, and we want our teams to be exercising clinical decision making and scene assessment. So we're not there to provide you with all the information. You know, we know from our mechanisms when we should be looking at spinal. And the bottom point there is, in order to facilitate the challenge, we need to have spinal precaution criteria. So, and it just sets clear guidelines for those participating in the challenge. So we'll move on to the next slide. To the next slide. Yes, cool. And again, I would suggest that none of the information here is new. Okay, these are fairly universal criteria for spinal immobilization. So if combined with a mechanism, we should be managing our spinal injuries. So, and this is for those competing, if you have these things, you really should be managing your spinal criteria. So, yeah, distracting injuries, impaired awareness, of course, and they're all listed there. Our immediate spinal midline pain, limb weakness. Our patients, our casualties, our volunteer casualties, and internal assessors will, of course, give you the answers either through words or actions, inactions. So there'll be no secrets. So I just want to stipulate that straight up. If you do a thorough spinal assessment, you will pick up those patients. Okay, moving on. Okay, so ongoing spinal care. So these are general guiding principles that, as one of the key changes and emphasised changes to this year's challenge, is a really patient-centred approach to all our treatment and care. So you'll see through our guiding principles that the patient is the focus of our actions. So so active spinal precautions, the terminology is used that active is your manual inline techniques with or without hard or soft collars and spine boards. Our passive spinal precautions are used when active spinal precautions are tolerated, and it involves reassurance and getting the patient to assist themselves. So a controlled, gentle movement, our self-extrication all come in as passive spinal precautions. Passive spinal precautions aren't just letting the patient do. Like, there must be some guidance and continuous engagement with the patient. So I'll just move to the third point here. Passive spinal precautions, when used, must include continuous engagement with the patient and controlled gentle movement. And this includes self-extrication and minimally assisted extrication. There are some contraindications. That's the inability for the patient to understand or follow instructions. And then the patient has a baseline function that prevents them from being able to assist themselves. So these are not only, so these are on-road practices as well as guidelines for the challenge. So as I stated earlier, if you listen and assess the patient, these things will be clear. We're not, there's no tricks, no changes. Let's go back. Yeah. And of course, if life-threatening injuries takes precedence over active or restricted spinal precautions. Okay. So just to break that down into some simple points, all teams are expected to apply spinal assessment and management principles as outlined previously. Active spinal injury care should be considered but not prioritised over life-threatening injuries. What, if I was to clarify that any further, that means just because someone has life-threatening injuries, we don't disregard our patient. You know, we need to still make sure that we have controlled gentle movement at all time, and that we don't just have heads and body parts flapping around. So, you know, it doesn't really require too much explanation, but from a challenge perspective, I just wanted to make sure that is clear. Passive spinal care is ongoing until assessment and active spinal care is and/or active spinal care is in place. If you're trained and you use spinal adjuncts, use them. If you're not trained in the use of them, then the expectation is that manual inline stabilization will form part of your active spinal immobilization. Okay. So just there's a quick glimpse of the guidelines, which I'm sure most of you have already had a look through. And these are just some of the areas where our spinal care marking comes in. And if you look through those, they're largely patient-centered in their approach and their scoring. So again, we're assessing and we're applying interventions that are appropriate to the patient. We're not just putting a spinal collar on everybody and putting them on a spine board, because we know in the real world that's not practical and it's also not appropriate. So we're shifting to what is appropriate care, a patient-centered care. Ian, I'm just wondering, before we move on to the next thing, which is related to the trauma marking and away from spinal, do we have any, excuse me, do we have any questions relating to the spinal stuff at this stage?
No questions have come through so far, Steve.
Okay, thank you. We'll move along. Okay. So this is so some of the changes and just running through those in relation to the trauma challenge specifically. And some of those, well, the main one being the move away from ABC to CABCD E. And the trauma team recognises that there are other models. As you can see, we're quite happy and able to identify March, which is primarily a military model, X-ABC, with X being extenuation, largely a Latin American model, as well as doctors C in brackets ABC. So what we want to see here is the management of catastrophic hemorrhage as the recognition of catastrophic hemorrhage as the number one cause of the number one priority that will otherwise kill you if not is where I'm trying to go there. Sorry. thing I'd like to mention, and this will assist those in the challenge as well as those assessing the challenge, is if you adapt a good systemic approach, a treat as you go, as identified by Michael in his secondary assessment webinar. So we'd like to see a good systemic approach, and the marking is around identifying an issue, assessing that using your tools. Look, listen, and feel is a good way, and then each appropriately before moving on. So, and as we work our way through our CABCD, I think there's nothing there that should surprise anybody. So we'll move forward. Medical actions. This is a good pause point for the challenge participants. And where you develop and communication with the development and communication of a plan. You don't need to tell the assessors what that is, but you need to communicate amongst yourselves, obviously, what that is. And the things we're looking for is the identified injuries and medical issues, the priority of the patients. So whether you have used green, orange, red, white, or black, or life-threatening, serious, non-serious, Cat 1, Cat 2, Cat 3. Again, much like our March and our XABC, we're not being fussy. What we want is just for the teams to be able to communicate their priorities and then go on to manage their priority patients. And of course, we'd like to see from that point, the priorities being patient-centered management and treatment. Secondary assessment, again, just a nice systemic approach survey. And I would suggest, we know the trauma challenge is only short. So concurrent activity through this would be, excuse me, recommended and encouraged. And so we'd like to see that happening and see the patient management moving forward. And we'll move on to a nice systemic approach, a good nose to toes. Again, this will assist identifying all injuries for the handover and treatment. Good solid communication with the patient. Remember that we are a patient-focused care is what we're aiming for. And again, good communication within the team. And if you've done anything as part of managing your primary survey, now is a really good time to go on and reassess those interventions. And just reiterating, a really good nose to toes, cutting down to the black underwear or underclothing that our volunteer casualties will be wearing, as well as a good patient history will be really beneficial at a later date during the handover. So patient-centered management, I'll let you have a quick look through here. I won't rattle them all off. I'll just read a couple of my little notes. Excuse me, sorry, I should have brought myself. Some water. So this again switches back to our patient-focused treatment and care. Things that I'd like to just reiterate here is don't expect to get full marks if you put all your patients on a spinal board without clinical indications or without proper assessment. Don't expect to get full marks for applying oxygen to all your patients without clinical indicators or full assessment. It's we are relating back to good, solid on-road practice. And one of the first things that I was taught when I was a paramedic, and I think it relates well to a challenge, is justify everything you do and justify everything you don't. And the assessors will listen to that. And there is, of course, debriefing that occurs. So, yeah, we would like to hear the rationales that, of course, you have. So, yeah, and all our again, as I stated earlier, there will be no tricks. There won't be patients who are pretending to be short of breath that aren't, or otherwise. So we'll move on. Transport and packaging, of course, and if you've watched the third webinar, there was a little bit of discussion, and it was very good discussion around the use of spine board versus a scoop, and injuries that where a scoop stretcher is probably far more appropriate than a spine board. So think about your selection of your transporting device. Make sure you're securing your patient for safety and comfort, which is, of course, really important. Safety is obviously important. Comfort is equally as important as the patient, as part of the patient experience. And we know that from the research that a patient's positive patient experience leads to better recovery. So, yeah, just remember these little bits of advice, and just, I think as you work your way through the challenge, just think about how you would do things on road and how you would normally manage a patient as well. And I'm sure that is with good, clear communication and reassurance, and making sure that they are comfortable when you move them as well. So we'll move on to the next PowerPoint. Got somebody else in the lobby. Scene management. This is goes right through from obviously the moment you walk into the scenario or an on-road incident, right through to the end. Things, of course, if I reiterate again, make sure the communication with the patient and your actions are patient-centered. Communication with the team and bystanders, situational awareness, and equipment awareness and management. I've got contamination there because that is one of my things that I, as a bugbear of mine, I do like to keep my equipment clean. And then planning and progress. So for the assessors, we like to see that you haven't gotten bogged down on the small stuff and you're continuing to move forward. And this might be part of your concurrent activity as well, just keeping things moving forward. Don't forget things like an extrication buddy. I know we're talking about the trauma here, but the same principles apply. Management of resources. You may have multiple patients and only limited supplies, so be aware of that as well. So make sure you are familiar with your kits. Most will be using the trauma kit supplied, I'd imagine. Make sure you take the time to really familiarize yourself with that kit. And yeah, and that's speaking from experience. So yeah, you don't want to be looking for your 10 mil or 30 mil saline in the wrong spot. Okay, as we move on. And there are a number of handover models out there. This is the model that we encourage you to use. This way we know that everything has been ticked off. Excuse me. And I would also encourage you to write down your numbers, your heart rates, your blood pressures, your respiratory rates, because they also provide a more detailed handover. And when you talk about treatment and trends and your signs and symptoms, they can be important. They are important and sometimes more important than others. A good patient history as well, as I alluded to earlier, with your allergies, medications and background. These are all ways of securing your points within the challenge. The challenge is a 10-minute scenario for both the complex and the standard. And we're looking at a 1 minute to prepare for your handover and 1 minute to give the handover in those scenarios. So unlike the extrication challenge where handover is given within the time frame, the trauma challenge, there will be a stop and then you can prepare and hand over. And okay, so this advanced procedures, I'm excited about this. There's been lots of questions around it. So I'll start only. And the first thing I want to amend at this stage is that there is a chance that advanced procedures will be applied in the extrication challenge as well. There's a couple of logistic things we just need to work out, but it was just going to be the trauma challenge, but we think we can get it through to the extrication challenge, which would be great, but there's still just a question mark on that one. But I do want to reiterate again, it is voluntary for 2023. Interventions are only within your current skill set. So if you have 2 jobs and one of those jobs you work as an intensive care paramedic and you are allowed to do a whole full set of skills and advanced procedures, yet you work a second job and you're competing as a BLS. No. You're competing with a different organisation that doesn't let you practice your ICP skills. While you are only allowed to use the interventions that your organisation that you are competing for. So within your current skill set, within the organisation that you are competing for. So at this point, mainly because we don't have the ability to implement a whole gamut of intensive care skills and other medical skills, the interventions are limited to cannulation for pain management and hypovolemia, needle decompression and cricothyrotomy. Teens may also wish to use advanced airways like LMA or intubation, and again, they will be a simulated procedure, of course. And moving to, so how will we keep these procedures safe? The biggest concern, my biggest concern is sharps, and this is what we're looking at with the extra care, is being able to manage and make sure that we have eyes on, from an assessor point of view, to keep our volunteers. The teams will vocalise the procedure they want to do. Prepare the site as normal, prepare the equipment as normal. Once the safety cap is removed from that sharp, the first thing what needs to happen is the sharp needs to be disposed of. The Teflon sheath, if we're looking at a cannula, can then be placed over the top of the skin and taped to the patient. The cannula would then be secured as normal and then flushed as normal as well, with normal only. So no other medications apart from being traveling with medications internationally, which was clearly a bad idea. Normal saline is the only thing that is to be in any kit bag that's not provided for the competition. And at no time will any sharp or drug be in contact with the casualty. So, any questions? Ian?
And there's none come through. Oh, can you hear me, Steve?
Oh, okay.
Yeah, there's none come through on the questions. If anybody's got a question, Cameron, have you got anything from your side?
I was just going to say, yeah, none come through though, but we'll give people maybe a minute or two to think about it. While we're doing that, I've got a couple of questions myself, Steve. Before we start,
yeah, for sure.
First of all, thanks very much to you, Mark and Eves, for all the work you've been doing in preparing for this. So a great bit of work, and thanks for taking the time to do the presentation. I'm sure it will have been of benefit to people. But I mean, there are some changes there. I am by no means medically qualified, but for thinking about teams, what are the sort of main things you would suggest to them as takeaways from this presentation? You know, what things should they be focusing on? Just a couple of lines. It doesn't need to be in depth. Just to you know, maybe point in the right direction. I've shared the questions that teams have already asked in the chat bar, so it's just for that. You know, I'm sure teams are very keen to get involved, but just, you know, what teams can be like. They can be a bit anxious sometimes when there's some changes. So if there's anything you can assist with that, it would be helpful. Thanks, Steve.
So yeah, thanks, Cameron, for the question. I think for the teams, if they on systematic and secondary surveys with their treater as they go with their primary survey particularly, that will be beneficial for them because it will make sure that they cover everything that they need to and find the injuries or medical conditions that the patient may have. If there's something that I would like to encourage within the teams, and that is to consider you doing the advanced procedures, challenge themselves in the procedure, practice like they would on road, and I think they would find it of benefit as well. It is voluntary, but I would encourage teams to consider using those skills if they've got them. And on that, if you are going to do that, I would also recommend you work your way through your primary and secondary surveys and use those skills when you've got the time to do them. They don't earn you points. So yeah, use them if you've got them, but don't make them the focus of your care as well. So yeah, I'd encourage the use of them. I'd really like to see teams take it up. I think it's going to add an exciting level to the competition. But back to your question, good systematic primary and secondary survey, Cameron.